So we covered the pulmonary ventilation per se, and now it's time to talk about factors that affect it. And we actually talked about three major things. The first is the pressure gradient airway resistance. Basically, if we want to write down the equation, the flow is proportional to pressure gradient and inversely proportional to the resistance. Does that make sense? Which means the higher the difference in pressures between the outside and inside, faster the flow. You good? Okay? And the higher the resistance, the slower the flow. Is the resistance significant? No, because it's air. Now, remember there's medium-sized bronchi, they small, and there's no diffusion there, so they will have the highest resistance. Now, you may ask why there is low resistance in small bronchioles. Remember what happens there? Why the resistance in terminal bronchioles is really, really small, despite of the fact that they are really, really tiny. Air diffuses through the walls. So it's not only going, imagine that you drinking, not just, so you're drinking through the straw and the liquid goes through the walls of the straw. So resistance becomes really small. Now surfactants here, okay, they function as to reduce surface tension in the alveoli. It's type 2 cells that produce it. Right, and it's proteins and lipids that actually provide this surfactant function. Reduces surface tension. Now, remember, we talked last class. We talked about this. How when alveoli inflate, surface tension increases, and as they deflate, it decreases. But when they are inflated, that high surface tension will try to collapse them, so surfactant is needed to reduce that surface tension, so they will be easier to inflate. And what happens to alveoli if there's basically no surfactant produced? They collapse, yes. Now lung compliance. That's the volume that you can inflate lung to with a certain change in pressure. The best comparison really for lungs are the balloons and tires. Think about this. To inflate, if you will make like 20 pumps into the balloon, it will be inflated because it's really stretchable. It has high compliance. If you will make 20 pumps into a tire, you may not even notice it because it's really not stretchable and has low compliance. So think about this. Lungs with a high compliance are easier to inflate. So in high compliance, it's easy to inspire, but it's really hard to expire. In low compliance, it's hard to inspire, but air leaves your lungs. Expiration is very easy. Okay? And remember, the main contributors to lung compliance, surfactant, yes, absolutely. Anatomically, elasticity of the stroma, so any type of fibrosis that can, harden, basically, increase the percentage of non-elastic connective tissue in the lungs, and different anatomical abnormalities of the thoracic cage, deformities of the thoracic cage, calcification and ossification of costal cartilages, and so on and so forth. Let's draw. That's a lung. Okay? So this is tidal volume. What is tidal volume? It's a volume of a normal breath. Now what is this? in inspiratory reserve. This is expiratory reserve. This is what we can expire on top of tidal expiration. And this is residual. Now, total lung capacity is all of them four added together. What's the vital? Everything except residual. What's the inspiratory capacity? Tidal plus inspiratory reserve. What's the functional residual? Say again? That's vital capacity. So all except residual. So this is vital capacity. This is the part of the lung that you are using. Now, functional residual capacity is this. Expiratory plus residual. So what you can expire and that little icing on the cake. Okay? Now, what is forced vital capacity? It's essentially vital capacity, but it is a measurable parameter. How can you, in its pure form, can you measure a vital capacity in its pure form in like a person without anything, without any invasion or any procedure? Can you know my vital capacity? Like from looking at me? No, you can't. You need me to forcefully expire. And the amount of air that I can expire from the peak of inspiration to the bottom of my lungs forcefully is called forced vital capacity. It essentially is the same as vital, but that's the term that is used in the spirometer measures. That makes sense? So if I would have spirometer and I will do this, what I exhaled is forced vital capacity. Okay? Now, forced expiratory volume, what does it measure? Think about this. It measures the rate of flow. So it measures how much air you can expire in a given period of time. Does that make sense? Because think about this. That's one expiration. I'm going to show you. I did it really fast. Imagine for a second that my respiratory passages are constricted. So what it would look like something. So I would take much more time to inflate lungs, and then I would do. Because airways are constricted, I cannot expire as fast. Does that make sense? So it measures the volume over a period of time. So that brings us to the obstructive and restrictive diseases. So obstructive disease, what does that mean? Blockage of respiratory passages. What's going to be altered in the obstructive? Forced vital capacity or forced expiratory volume? So if it concerns my respiratory passages, my lung volume will be affected or not? No. Think about this. That's a balloon, okay, with a pipe in it. Lung is the balloon with a pipe in it. In obstructive disease, pipe becomes narrow. the balloon volume remains the same. So vital capacity doesn't change, but my ability to expire air in a certain period of time is diminished. In restrictive disease, the balloon volume becomes smaller. So in restrictive disease, vital capacity decreases, while the expiratory volume is either unaffected or minimally reduced. Does that make sense? Okay. Now, minute ventilation, you will have to calculate it. Yes, of course you can use calculators. Okay. So, minute ventilation is what? Tidal by respiratory rate. That's it. How much air gets in the respiratory system. Okay. Now, what is the dead space? That's where the gas exchange doesn't happen, right? So, what are two types of dead spaces we know? So trachea, bronchi, and everything else. Do you have trachea? Do I have trachea? We all have trachea. So that's anatomical dead space.
Oh, I didn't know you were the name. Okay.
Anatomical and alveolar dead space. Alveolar, non-functional alveoli. So say anatomical dead space, is it going to change throughout your adult life? Most probably not. Alveolar dead space, it may change if you get pneumonia. You have dysfunctional alveoli. Make sense? So how do you calculate alveolar ventilation rate? Frequency of breathing multiplied by tidal volume minus dead space. So basically you multiply the breathing frequency by the actual air that gets in the alveoli, in the functional alveoli. Does that make sense? Awesome. What ventilates better? Slow and deep or shallow and fast? Slow and deep. Do you understand why? Because dead space doesn't change, but minute and it actually increases alveolar ventilation profoundly. Because of with each breath you bring way more air into the lungs. Does that make sense? We're good. Any questions about this? Just know them. No specific details. Know what causes them. Nothing too exciting, like coughing, sneezing, irritation, yawning or hiccuping. We don't know the exact mechanism. Hiccuping is probably diaphragm irritation. Crying, laughing, emotional responses. That's it. That's as far as it goes. I'm not really focusing on these movements. We're good. It's like really insignificant moment here. So, Dalton Law. The pressure of the mixture equals the what? The sum of all individual partial pressures. Does that make sense? So, if you have gas A, B, and C, then the pressure of their mixture will be equal PA plus PB plus PC. So it's going to be pressure of the mixture. Partial pressure of a gas in the mixture is proportional to its concentration. Does that make sense? So which gas has the highest partial pressure in the atmosphere? Nitrogen. Right? We're clear? Awesome. Henry's law states that concentration of gas in the solution, in the fluid, in the liquid, is directly proportional to its pressure of the liquid. The higher the pressure, the more gas you're going to get in this solution. Does that make sense? You good? Is that understood? That's basically it. Okay. So in the at the equilibrium point, the partial pressure of the gas above the liquid and in the liquid, those pressures are equilibrium, huh? Same, yeah, equal. So if you change one, then the gas will move to the lower pressure. Remember that always. When temperature goes up, what happens to the solubility? It decreases. Yes, yes, it decreases. And when it cools down, it increases. Very clear. That's all you have to know. Just have an idea about those things. And they're pretty straightforward. Now, lungs and atmosphere. So we're talking about 4 components. So we have nitrogen, oxygen, CO2, and water, right? So in the lungs versus atmosphere, nitrogen in the atmosphere compared to nitrogen in the lungs, which pressure is higher? Yes. Oxygen, atmosphere, CO2, lungs and water. Why? What happens in alveoli? I'm not asking any tough questions now. Trust me. What happens in alveoli? Gas exchange. CO2 in alveoli, where does it come from? Mostly. Atmospheric air or blood? Blood. That's it. CO2 goes up. There's a lot of fluid in alveoli. Water vapors go up. Now, overall pressure, without any expiration, inspiration, overall pressure in the lungs and the atmosphere, are they equal or different? If I'm not breathing, equal. So if you increase the proportion of these two, you have to decrease the proportion of these two. That's the proportion idea. That's it. Does that make sense to you? We're clear. Understood? Clear? Awesome. What helps respiratory membrane to perform its function? Which two structures? Two structural features. Respiratory membrane is composed of what? So, alveolus, the alveolar membrane, capillary membrane, and basement membrane between them. So, respiratory membrane is what? Thin, and surface area is huge. That creates thin, ensures that the gas exchange is fast. Huge area facilitates diffusion as well. So if there's fluid, what happens to the thickness of the membrane? Increases, and in emphysema, surface area of alveoli decreases. It kind of, I put the answer there for you. Just remember, you know, basically, like, what will worsen the respiratory function? Decrease in the surface area, the respiratory membrane. So why question is answered right there. Let's quickly go over gas exchange and transport. I am not going to ask numbers. I try to think The only numbers that I'm going to ask you to do, minute alveolar ventilation rates. Calculating. I'm going to give you numbers. You just need to, subtract and multiply. That's it. Am I clear? I don't want you to memorize actual partial pressures. So, ratio-wise, in the alveoli versus pulmonary capillaries, oxygen pressure is higher where? Alveoli. So, in the lungs, oxygen goes from alveoli to blood. In the alveoli, carbon dioxide pressure is higher in the blood. So CO2 goes from blood to the air in alveoli. Clear? Then this whole thing goes through the pulmonary veins, on the left side of the heart, blah, 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 systemic circulation. In the tissue, oxygen pressure is higher in the blood, so oxygen goes tissues. CO2 pressure is higher in the tissue, so it goes in the blood. Returns back. Does that make sense? That's really simple. Always remember that diffusion. Now, think about this. I probably spent same amount of time typing this thing as we spent now just going over the whole respiration process. Okay? Yeah, I do like Hugh Laurie, but it's not him. It's high. Okay? It's high. Ventilation and perfusion coupling. We break it down. I'm not going to create some really horribly tricky questions about combining them. Let's talk about perfusion first. What is perfusion? It's no tricky question. What's perfusion? When I say perfusion, what do we refer to? Huh? Blood flow. So in this case, perfusion is the blood flow through pulmonary capillaries. Okay? Now, if you have an alveolus with elevated oxygen levels in it, what's going to happen to its perfusion? High oxygen. Increase, because we need to pick up that high oxygen. What increases that perfusion? That may be a little bit more complex question. What is the mechanism for increased blood flow to the alveolus? Dilation of? Nope. Nope. What dilates? Capillaries cannot dilate. Huh? No. Blood flow. Arterioles. Does that make sense? Arterioles that eventually will branch into those capillaries, they will dilate and will send blood into the network of capillaries around that alveolus. Does that make sense? If oxygen is low, perfusion is low because of what happens to arterioles? Constriction. We're clear about this relationship. Are we? Awesome. That's perfusion. Ventilation. What does it deal with? Which gas? CO2, because we need to get rid of CO2. So if CO2 in the alveolus is high, what do we need to do with CO2? Get rid of it. How? Through what? Dilation of bronchioles. Perfect. Dilation of bronchioles. CO2 is high. Now, for a moment, just bear with me. I will try to connect these things. Think about this. You have alveolus. It has a lot of CO2. If CO2 is high, oxygen levels are low. So in this alveolus, perfusion is diminished, but bronchioles start to dilate. CO2 leaves the alveolus. What happens to the oxygen concentration? It goes up. As it goes up, bronchiole constricts, but arterioles dilate and increase perfusion. So it's a balance all the time. Are we good? Clear? Fantastic. What carries oxygen in the blood? Hemoglobin. Does plasma carry anything? Just that much. Just few. Okay. Not really significant moment. How many oxygen molecules can one hemoglobin carry? 4. What does it bind to? Iron. It binds to iron. It's like, I don't know if you have this story, it's like the life of some evil magician is in the egg is in the duck is in the chest is on the tree, and there's one Russian story about some evil dude who had his life protected by multiple layers. So oxygen binds to iron. Iron is a part of which molecule? Heme, and you have these 4 heme molecules in hemoglobin. And each heme molecule is bound to a separate subunit. If hemoglobin bound 4 oxygen molecules, what is its saturation? 1 molecule, 25. This, I'm not going to ask you these numbers, but you got to understand what it is. Okay? Oxyhemoglobin, where are you going to find it? Oxyhemoglobin. On which part of the circuit, basically? Like, it will be on the way from alveoli to tissues. And deoxyhemoglobin will be tissues to alveoli. Does that make sense? Pretty straightforward. Cooperative binding. Each next oxygen binds easier than the previous one. Make sense? Ugh. Hemoglobin dissociation curve. Favorite topic of every student. Is there any, very fundamental question, is there any law underlying, like equation, that describes hemoglobin dissociation curve? Or is it no? Just empirically observed. It is what it is. That's actually the phrase that I could never understand when I watched ESPN. They interview some players and yeah, you know, it is what it is. Dude, you didn't say anything, you know? You just mumbled some words. You didn't explain why you lost or why you won. It is what it is. But in this case, that's it. There's no like higher logic to it. It explains the adaptation though. Okay? So what's on the x-axis? Oxygen pressure. What's on the y-axis? Saturation of hemoglobin. We're going to put percentages. So what happens when, okay, partial pressure of oxygen, where is it high? Body-wise. Where is oxygen partial pressure, oxygen concentration? Where is it high? In the lungs. Yeah. So that's going to be lungs. 100 is lungs, right? Now, if you start in that, high partial pressure of oxygen area, like here, that's going to be, say, 80. In that area, if you decrease oxygen partial pressure, saturation doesn't change much. So we have this shape, right? And then as the oxygen partial pressure decreases, the saturation that corresponds to that pressure decreases, right? Something like that. So it's horribly not up to scale. So say this is 40 and the saturation becomes 75. Okay, now this 40 is in tissues. We just know that. We measured that. So What does that mean? That hemoglobin had 100% saturation in alveoli and 75% in tissues. Where does 25% go? Where did they go? No, just into tissue. Because think about this. When oxygen pressure drops that much, this is what's left. This is what hemoglobin cannot give at this pressure. That's it. That's what's left. So this 25% are unloaded during normal, like, resting state. So the 75%, we call it how? Venous reserve. So it gives us some depot of oxygen in case of emergency, right? Does that make sense? So far. Now, if you go in the mountains, what happens to the partial pressure of oxygen in the atmospheric air? Decreases. Partial pressure of oxygen in the alveoli what happens? Well, I said it. It decreases. Now, it means that your lungs are not 100, so that's resting. It's not 100, it's, say, here. That's mountains. That makes sense? What happens to hemoglobin saturation? Does it? No! No! Look. This is mountain. That's the hemoglobin saturation that corresponds to our alveoli in Colorado. It doesn't change much. Is that understood? We really have to go way up to not saturate hemoglobin. Does that make sense? Got it? So that's adaptation to the changes in the elevation. Now, when we exercise, say we exercise at the sea level. So lung part at the sea level stays the same. Everybody agrees with that? Because nothing changes. What happens to the tissue part? What happens to the partial pressure of oxygen in the tissues as we exercise? It goes down. Why? Huh? We use oxygen, right? For exercise. So as it goes down, what happens to unloading? It goes, it creases. Excellent. As your tissues require more oxygen, oxygen unloading increases. Does that make sense? Like a hypothetical situation. Instead of this S-shaped curve, you have a straight line. What you wouldn't be able to do? Huh? Well, no, exercising is fine actually, because you have a lot of loading, and as your concentration in tissues decreases, downloading increases. That would be fine. You wouldn't be able to go to Colorado, because you go from 100 to 90, and if it's a straight line, imagine for a second that that's a straight line. You go from 100 to 90. Well, I didn't connect it well, but say you decrease. You unload it, your saturation drops precipitously. You wouldn't be able to bear this. Now, if that would be, it's a terrible perspective, then it would be a flat line. Like hemoglobin saturation is the same at any pressure. What does that mean? In 2 words. Would you be able to unload hemoglobin? No, you die. Does that make sense? So if we would put this graph like horizontal line, it means you die. Because it doesn't matter which pressure there is, hemoglobin just keeps holding on the oxygen. Does that make sense? You good? So, deep breathing. Think about this part. Deep breathing, deep, rapid breathing. Does it increase saturation significantly? No. Why? What is the saturation level at the top here? What is the hemoglobin saturation level? Almost like 99.5. You cannot go above 100%. You cannot do 110% saturation, right? So that's it. It's already saturated. Bringing in more oxygen does not really help. Are we clear? Can we? Yes.
So, is that why, like, when you're exercising, like, the saturation is at like 40? So, like, is that why like, your body tries to breathe deeper when you're exercising to bring more?
When you exercise, the amount of oxygen in the tissues decreases. Also, your tissue metabolic activity increases. So the total amount of oxygen that has to be transported to tissues goes up. This is why you breathe harder and more frequently to maintain the saturation in your alveoli at the same level. Basically, think about this. If you have, like, at rest, you have one truck going through your alveoli, picking oxygen a minute. When you exercise, you have 10 trucks because your cardiac output goes up, right? And blood flow increases. Since you have 10 trucks, you have to breathe much harder to load them all. Does that make sense? Did I explain it? Good. So, in the now let's try to use our imagination and talk about factors that influence hemoglobin saturation and unloading. Okay, unloading. Let's talk about actually like unloading. Elevated temperature. How does it affect unloading of oxygen? Increases. Lowered pH increases, and high CO2 partial pressure also increases. So if you want to figure out, if you see a question which asks about the role of a factor in unloading, you have to think about metabolically active tissue. CO2 is high, oxygen is low, pH is low, temperature is high. Does that make sense? And vice versa. Now, hemoglobin dissociation curve in metabolically active tissues. Is it going to be shifted to the right or to the left? Huh? Think about this. If unloading is easier, then basically oxygen is looser. So hemoglobin saturation should be lower. Do I make sense? So this is normal curve. The curve at the high temperature will be like this. Does that make sense? So at the same partial pressure, there will be more unloading than in the normal state. Does that make sense? So therefore, cold, high pH, high oxygen, low CO2, they will shift the curve to the left. Got it? So yeah, I'm going to ask you, and that shift, that CO2 is high in the tissues. CO2 promotes the unloading of oxygen from hemoglobin. This is called Bohr effect. Are we good? Awesome. Well, we kind of just did. Can you characterize metabolically active tissue? Can you tell me? In metabolically active tissues, temperature is high. What is next? pH is low. CO2 concentration is high. Oxygen concentration is low. We good? Lungs, just flip it. So, hemoglobin saturation in the lungs is high because unloading is low. That makes sense? You have more oxygen bound to hemoglobin because it doesn't unbound. Okay? Types of hypoxia. Anemic. What do you have low? Red blood cells. Ischemic. Low blood flow. Histotoxic. Tissues can use oxygen. Hypoxemic. Just don't breathe enough. Does that make sense? Carbon monoxide. Okay, kind of prefacing. So carbon dioxide. What does it bind to? CO2. What does it bind in the hemoglobin? CO2 binds. Which part of hemoglobin does it bind? CO2. Which part? Protein. Carbon monoxide binds. Why carbon monoxide is bad? It binds iron. It competes with oxygen directly. CO2 does not compete with oxygen. Carbon monoxide does. So carbon monoxide binds to the iron. Okay? So when carbon monoxide binds to the iron, and it binds so awesomely well, okay, how does it change the amount of oxygen that's transported to the tissues? Decreases. Do humans produce carbon monoxide? Yeah, we do. Not only we produce it, it's really good anti-inflammatory molecule, it turns out. We just produce such small amounts, but it's like really important in cardiovascular signaling. Okay, CO2 transported in the blood. You're going to tell me what to draw, and I will draw. What are the options? Let's talk about plasma first. Directly dissolve in plasma. It's boring. We're not going to talk about it. I mean, just remember, there is a plasma component. What else can happen in the plasma with CO2? Huh? So CO2 can interact with water and form, carbonic acid. And carbonic acid will dissociate into bicarbonate and hydrogen. Remember, this is slow because there's no enzyme. Okay? What happens to hydrogen? Binds to albumin, binds to plasma proteins. Bicarbonate serves as a buffer molecule. Good? Okay. What happens in the red blood cell? Same. You can say the same, right? Same exact stuff happens in the red blood cell. Is it fast or is it slow? It's faster because what we have here, the enzyme, carbonic anhydrase. What happens to hydrogen? What does it bind to? Hydrogen, what does it bind to? Binds to protein. Which protein in red blood cells? Hemoglobin. It binds to hemoglobin. And think about this. This reaction that I showed, this one, essentially takes hemoglobin away from the dissociation reaction of oxyhemoglobin into deoxynoxygen. So oxygen happily goes into the tissues. Hemoglobin binds hydrogen. Does that make sense? So this hydrogen binding helps hemoglobin to unload oxygen. It shifts the equilibrium of this reaction. It shifts the equilibrium to the right. Does that make sense? Because hemoglobin goes here. We clear? So again, what is the role of bicarbonate in plasma? It's a buffer. Oh, bicarbonate in red blood cell, where does it go? Where does bicarbonate go from red blood cell? Come on, there are not so many places. There's only one option. From red blood cell, it can go only where? Seriously? What's outside of red blood cell? Well, not plasma. It goes into plasma, that's it, and it stays there. So that bicarbonate provides a buffer capacity to plasma. Does that make sense? That's it. Now, in the pulmonary capillaries, what do we need to do with all the arrows? Just flip them. It all happens backwards. Does that make sense? That's basically it. So hydrogen that is bound, that's specific. Hydrogen that is bound to hemoglobin. This hydrogen, this hydrogen binds to bicarbonate, forms carbonic acid. Carbonic acid dissociates into the CO2 and water. CO2 is exhaled. That's it. So again, it's all about CO2 plus water, bicarbonate plus hydrogen. Make sense? Any questions about this? This is simpler than you think. So I strongly suggest, and there's an exam, draw this. Seriously, draw this. In many cases, like if I need to remember something, I will draw it first to answer questions. Bicarbonate buffer system. If you have extra hydrogens, what is it going to bind to? Huh? Exactly. And form carbonic acid. And it will dissociate in the water and carbon dioxide, blah, blah, blah. If you have extra, well, technically speaking, this. Well, base. If it becomes alkaline, what is it going to bind? Hydrogen. It's going to bind hydrogen and form, surprisingly, water. So it's going to manifest as extra bicarbonate in the blood. Does that make sense? And carbonic acid will start to, basically, to supply this, it will come from carbonic acid dissociation. Right? Hyperventilation. How does it change the blood pH? Low. No. Don't trick me. Hyperventilation. No. Hyperventilation. When we hyperventilate, what do we get rid of? CO2. CO2 equals what? Acid or base? CO2 is acid. When we get rid of CO2, what happens to the acidity of the blood? Decreases, pH increases. When we don't breathe enough, CO2 concentration in the blood increases, acidity increases, pH goes down. So, metabolically, what is more likely to happen? Alkalosis or acidosis? Acidosis. In acidosis, what you can observe in a patient? In terms of the breathing rate. If the blood is acidic, what is the respiratory response to it? Increase respiration to get rid of CO2. Make sense? Okay, VRG, what does it do? Sets the rhythm. DRG modifies the rhythm, adjusts to metabolic changes. Pontine respiratory center. Smoothens out the transition. Now, VRG, what does it communicate to directly? Why do we breathe? No. Why? I mean, what produces the movement? Muscles. Muscles, right? So VRG communicates to muscles. DRG communicates to VRG. And pontine respiratory centers communicate to both ventral and dorsal respiratory groups. Does that make sense? Which types of receptors are most critical in the regulation of respiration? Most critical. Okay, let me rephrase it. As we just discussed, what will make you breathing faster? In terms of the blood, lower pH, higher CO2, lower oxygen. We're clear. What senses all of that crap? What type of receptor? Chemoreceptors. Clear? That's it. So, everybody understands. Low pH, low oxygen, high CO2, increased respiratory rate, increased depth breath. You change it, decreased. Are we clear about it? Which factor contributes the most? CO2. Second place is taken by pH. We still, if we say a lot of lactic acid, we'll still breathe harder. And the third place is oxygen. Why oxygen is not that critical? Venous reserve. That makes sense. Now, if we hyperventilate, I'm referring to this. If we hyperventilate, blood CO2 goes down, blood pH goes up. You need to review pH. Now, think about this. Acid, low, base, high. So, you get rid of CO2, you make it basic, pH goes up. Okay. What is the response of cerebral vessels to high pH, low CO2? What do they do? Constrict. They don't shrink. They constrict, yes. They constrict, so blood flow to the brain ceases, fainting. Make sense? That's it. Apnea, sudden drop in CO2 concentration, which causes the stoppage of breathing, basically. We answered this question. Do we understand? We just answered it. Role of hypothalamus. It hurts. We breathe. Okay? That makes sense? Can we control breathing voluntarily? Yes. Can we suffocate? No. If CO2 becomes too high, we're going to take an actual breath. Okay. Irritant reflex. That's simple. We get dust in the respiratory passages, we cough or sneeze. Clear? That's it. So, coughing, sneezing. 3 main factors that increase respiratory rate during exercise. First of all, we know that we're going to exercise. So they're all neural. So psychologically, we know that we're going to exercise, right? Then muscle movements and increased motor activity from the cortex. Does that make sense? So it's basically the co-activation of motor centers and respiratory centers at the same time. Does that make sense? CO2 concentrations, oxygen concentrations, pH in the blood. Do they really change during exercise? They do not. Because ventilation increases, perfusion increases, saturation stays the same, everything is staying the same. Does that make sense? Why muscles nevertheless switch to anabolic respiration, fermentation during exercise? Why does it happen? Is that a failure of respiratory system? Which system fails to deliver blood? Which system fails? Cardiovascular. It's question? It's either insufficient cardiac output or just squeezing the blood vessels. Okay. Exposure to the high altitudes. What happens to the hemoglobin saturation at extreme, like if you suddenly go to Mount McKinley, the very top? What's going to happen to saturation of hemoglobin? It's going to decrease. So how does it affect the oxygen delivery to the brain? It decreases. How does the decreased oxygen delivery to the brain affect blood vessels? Huh? You're going to dilate immediately to maintain the same level of blood flow to deliver that oxygen. Immediate vasodilation in the brain leads to edema. So in the brain, edema. In the lungs, blood perfusion will increase trying to get all the oxygen out. So pulmonary edema. That makes sense? So that is the short-term adaptations. 2 major ones. Increased sensitivity of chemoreceptors. With the lower oxygen levels, they have to become more sensitive to CO2. And what else noticeably changes? The ventilation rate, yes. Basically, your alveolar ventilation will increase. That's short term. Long term, what increases? Red blood cells. Okay, clear? So, I will clarify it for you. As the obstructive disease, as an example, I really want you to understand the idea of bronchitis, chronic bronchitis, and asthma. Chronic bronchitis obstructs the respiratory passages with mucus, asthma with a constriction. Does that make sense? Emphysema, I want you to use it as an example of restrictive disease because alveoli become destroyed. Does that make sense? So vital capacity of a lung goes down in emphysema. Does that make sense here? What are the treatment options for obstructive diseases? Bronchodilators, anti-inflammatories, mucus loosening drugs. If it's bronchitis, still remember, like when I was a kid, I had allergic bronchitis for several months. I finally came to the specialist. She looked at me and said, "Yeah, it's a chronic bronchitis. Go home." I didn't realize what she was telling me then, and I told my second aunt, who's a doctor. I said, "What? Chronic bronchitis? You 10. You're not smoking. You're not living in the polluted area. That's BS. You don't have chronic bronchitis." Now, TB. What do you need to know about TB? That it's an infection of the lung caused by bacterial disease. Wrap it up. Treatment options: antibiotics. Lung cancer rate, highest. Main cause of cancer death in the United States. Main underlying cause: smoking. Treatment options: early diagnosis is the best treatment. Chemo, radiation, surgery if it's early. Prognosis depends on the stage. For the first stage, it's actually pretty good. For the fourth stage, extremely poor. Fetal lung active is not active because it's filled with fluid. Gas exchange occurs in the placenta. What decreases respiratory? Thoracic wall structure with age. What happens to it? It becomes more, it decreases and becomes more stiff. Respiratory passages become laden with mucus usually. Just general inflammation increases. Elasticity of the lungs usually decreases, and alveolar size increases. So it increases, but the surface area goes down because of this. Does that make sense? Cystic fibrosis. What happens in the cystic fibrosis? What people are deficient for? Chloride channel leads to abnormal chloride accumulation on one side of the cell, leads to mucus accumulation. Respiratory component of the disease. What I'm referring to is how do you get rid of mucus? Mucus thinners, really? Auscultations of a chest, that's it. And yes, saline inhalation. It's actually like a really big deal. Antibiotics, because mucus is a great place for bacterial growth. Actually, I don't know if you saw it. I saw it a few months ago in the news. There's a cystic fibrosis patient, a young girl, in her like 18 or 19. She received lung transplant. It's actually a viable treatment option. But the thing is, think about this. If you have lungs and respiratory passages, you have to first, in patient with cystic fibrosis, you have to do very aggressive antibiotic therapy, extremely aggressive, to basically sterilize this thing. And in case of lung transplant, you're not really caring about lungs that are removed. You care about the respiratory passages that are left. That makes sense here. So that girl got treated with antibiotics. They removed the lungs. They put the new ones in. Turns out there was a microorganism called Burkholderia malii, which is bacteria, sitting basically right there in trachea. And this microorganism, which is now, due to our antibiotic treatment of cystic fibrosis, is notoriously resistant to all antibiotics known. So this microorganism invaded her lungs. So she has pneumonia caused by totally drug-resistant bacteria. And she literally ran out of options. There are no treatments. And they're going to seek treatment from some institute in the, not U.S. state of Georgia, but country of Georgia, which is the world leader in phage therapy. So they're going to try and identify viruses that will kill that bacteria and will essentially sterilize her lungs, which I think is pretty awesome. Really. She'll probably inhale this. I don't know, I didn't follow up on that. But that's one. Some people just, they will just seek the treatment because that's the only final option. That is. Yes? I don't know. I don't know. Maybe because of the rejection issues. Maybe because of the surgical complications. I know that in children, it's called tracheal atresia. There are some kids born basically without the trachea, which is a horrible condition. And one of the options that is investigated now is to grow, well, make on the 3D printer, make artificial framework, like cartilage, and then seed it with the stem cells. There was a huge scandal recently with a guy from Sweden, surgeon who tried this therapy, and according to his own reports, it was a huge success, but a lot of his patients actually later died. And basically, they investigate the ethics, like, were they informed properly? And I get it. Like, if there's a kid without trachea, this kid's gonna die sooner or later. So we might as well put the trachea, artificial thing, into this kid. But the kid and the parents, they have to be informed of the possible complications. So, okay, let's take a break and we'll review the